Hello, T4 friends. I am so glad you are here today. We have a very special guest, a cameo appearance of Dr. Peter Leo, and it's so appropriate because it is National Eczema Awareness Month. So what a great time for Dr. Leo to be talking to us since he has so much expertise in both atopic dermatitis and the topic that we're talking about in our patient perspectives. And he has been a real champion of the patient perspective in this condition. Topical steroid addiction, some people call it, that's the problem. And then when we stop it, it leads to topical steroid withdrawal syndrome. And again, it is something that's controversial and I'm not quite sure why. So I'm going to let Peter take it away just because he's well known to all of us. He's had great training and I just can't wait to hear from him. He squeezed us in before he has to run to the airport. So I want to let him take it away.
Thank you so much, and thank you for having me. This is such an interesting time because we are learning more about atopic dermatitis and eczema than ever before, and there's all these new treatments, and I can't thank the manufacturers enough for bringing us new non-steroidal treatments because it's against a backdrop of this very bizarre condition called topical steroid withdrawal, or TSW. And usually I call it topical steroid withdrawal syndrome because it really does seem to be bigger than just a concept of, withdrawing. I've had people say to me, well, of course, if somebody has a chronic inflammatory condition and they're using steroids, if they stop, of course they're going to have a flare-up, but this seems really different. So it's really timely, I think, that we have this. Couple of things that I just wanted to go over. The first was, this is my favorite figure, and this is one I actually want to get a tattoo of somewhere on my body because it's amazing. And it summarizes all of the key pathogenesis aspects of atopic dermatitis. At the top, we have the barrier damage, we have the microbiome being in disarray, we have the inflammatory component, we have the sensory nerves, and then we even have the behavioral piece, the scratch itch cycle. And I really feel like these are all at play in making atopic dermatitis something really, really tough to treat. Of course, steroids, both topical and even systemic, even though, of course, we try to avoid the systemic steroids as much as possible, they really help, right? They help a lot of patients and they cool the itch. They help with the inflammation. And to some degree, we even know, for example, staph bacteria, Staph aureus, if you treat with topical steroids, it actually gets better to some degree. Obviously, if there's an infection, we don't want to do that, but we know there's often overgrowth. So steroids are a reasonable first line. But I often say there's something like a deal with the devil because they can make a lot of patients better. And if they're using them carefully, intermittently, they're fine. But for those patients where they're needing them over and over and over or constantly needing them, we have seen more and more people having trouble coming off, or what I like to call the pattern of escalation. So when I think about our patients with atopic dermatitis, some of the patients have a real spiky condition where they get bad flare up, then they're better, bad flare up, then they're better. Other patients have more of a seasonal type of a spike, like the one on the lower left, where maybe they're good for most of the year, then in the winter they really have a bad flare up. But the top middle is my favorite. That's what we want. We want that damping pattern where they're like, "Oh, I'm better and better. I'm good. I haven't needed the medicine in weeks." And that's the patient I feel good about. I'm saying, "You're fine. I'll see you in a few months." It's the one on the upper right that I'm most nervous about. That I call escalating pattern of disease. And this is, to me, the most sensitive marker for somebody who might be at risk for this TSW, meaning, you've had them use maybe their triamcinolone or mometasone or whatever it is that they're using. And as soon as they stopped, it didn't go back to baseline. It actually seemed to get worse. And then they needed it again, maybe even sooner. And they're like, boy, I needed more and longer. And then they're coming in saying, can I get something stronger? When I hear this, I say, uh-oh, we're going the wrong direction. And I've now known about this for more than a decade, but it's actually been described even before we wrote this paper. This is a paper we put together back in 2015. And this was sort of a review of the literature, but there are papers going back, at least 30 years with this idea, although surprisingly, it just didn't seem to be very common until more recently. And what we think is going on here is that topical steroid withdrawal is this poorly understood. It is a distinct adverse effect, though, of steroid use. Most commonly, it's been described being in the face or genital area, but in my patients, kind of the modern version of this, almost all the patients are more erythrodermic. They have very widespread disease or near erythroderma, like at least 70 or 80% body surface area. They often report stinging and burning. And it's pretty intense, and it has a huge impact on that quality of life for them. So I think the most sensitive piece is that pattern, but I don't have any evidence to back this up, and we've been working really hard to try to develop some clinical criteria. In fact, we're going back and forth right now with a journal trying to get this sort of we not even wanting it to be diagnostic criteria. We just want to sort of say this is the sort of the raw materials, the baseline where we can start building a diagnostic criteria. But some of the things that come up are some very specific terms. You'll see here elephant wrinkles, red sleeve, headlight sign. And this is an example of what's called the red sleeve or the sleeve pattern. Patients have kind of looks pretty much like eczema. It could be severe eczema, but then it has a strange cutoff at the wrist. You can see that. And just so you know, it's not a one-off. Here's a whole bunch of patients with the same pattern. And I would say that if I saw this, 10 years ago before I knew about this entity very well, I would say, okay, I guess it could be atopic dermatitis, but it's very strange. I would say I think this is more like a contact dermatitis pattern. Maybe they're allergic to their clothing, but we've tested dozens of these patients now and done lots of patch testing, probably more than 30 or 40 of them, and it almost never bears out that way. The other one is this concept of elephant wrinkles, which is a little strange term. It came from the community. It's not maybe something we would use in dermatology, but fascinating. Sort of thickened skin, edematous skin. If I didn't know, I might think, is this mid-dermal elastolysis? Is this some early elephantiasis, varicosa nostra? But it's not. And biopsies are also not showing any of those entities as well. But again, you can see this kind of strange edematous, redundant skin that does eventually get better. Another piece that we see for these patients is this very dry skin, almost like an exfoliative erythroderma in the aftermath, where they're just having so much exfoliation and sloughing. So we kind of coined a term, I don't know if it will stick, but we called it arderema, which comes from the Latin for burned or dry, burned like ash. And this idea that no matter what they're doing, they're having tons of flaking, so much so that the patients call it snow, this extensive exfoliation. So we're working on this diagnostic criteria, but I fully and freely admit that it is extremely difficult to distinguish this from really bad atopic dermatitis. And in fact, I give almost all of my patients both diagnoses. So when I'm using medicines for it, I'm giving them the diagnosis of atopic dermatitis because I feel like that is a big piece. I will say, though, that we're late to the game. In the United Kingdom, the government has recently approved a new warning on topical corticosteroids, actually calling out topical steroid withdrawal. So we've been talking with the CDC about getting a formal diagnostic code here in the US, and they sort of said, well, we don't really love the name. Can you guys come up with a new name? And I said, we could try, but the cat's out of the bag. In other countries, this is already what they're calling it. So I think it may work against us and our patients if we try to give it a different name. I agree, it's not the best name, but we've tried for years to come up with something better. And I think it's sort of after a while, you call it what it is. But this is what the warning looks like in the UK. And that's, I think, a big deal because that's a government regulatory body now saying it. The last little bit I'll say is just that we've done some biopsies on these patients as well. And it really does, for all the world, look like atopic dermatitis. So the histology has not been helpful. We see some perivascular lymphohistiocytic infiltrate, a little bit of spongiosis in the epidermis, but it's not that helpful when we look at it. So what can we do? What are we doing for these patients? Well, one is we're really trying to avoid overuse of steroids. I'm not anti-steroid. I'm really not. I still use them a ton, and I think for many patients, they're really a great resource. But I feel like we have to be careful if people are overusing them. So good steroid stewardship is the key, which I don't think is that controversial. And in fact, I wrote a paper recently where we talked about sort of a plan that's all non-steroidal, because I have a lot of patients who say to me, can we just completely avoid all steroids? So we put this together recently, which was kind of fun. And then for the patients that actually have TSW right now, I'm really worried about them. We've talked about some of the different things we can do. In my hands, the three most important modalities. Number one, phototherapy. I really like narrowband UVB phototherapy. It's time tested for atopic dermatitis and, of course, other things like psoriasis and vitiligo. It's generally covered by insurance, and it's not a medicine at all. So I think a lot of the patients are like, okay, this sounds like something totally different. If that's not helpful or not possible, my number two is dupilumab. And that is, again, typically indicated for moderate to severe atopic dermatitis. But again, these patients have that overlap. And I've written up a report where we've seen improvement from it. It's not a cure. It's not a magical, I wish it were magic for everybody, but it definitely seems to help. And then the one that's been most time tested is cyclosporin. And there's a whole literature on this even from decades ago where people have found putting them on cyclosporin. Again, we used it off label for many years for atopic dermatitis as well, can be really helpful. So I think that's kind of the state of the art. There's a lot going on right now as we try to learn more about it. And I really do worry about the patients that have it because it has such a big impact. But the hardest part is the insult to injury. A lot of clinicians I meet say, I don't think it's real. And I'm like, but there's actually a pretty good amount of evidence now. Even in the Journal of the American Academy of Dermatology, it's been published. There have been a few updates. Of course, this is a reference for the paper where we talked about dupilumab being helpful. This was in JAD case report. So I think it's out there. And of course, some of the government bodies are already recognizing it. So I just want to be a resource for patients and clinicians if they have questions. And I often say, even if you're skeptical, I don't think you have to do anything different than just doing what we normally do. If somebody's overusing steroids, you'd say, hey, maybe it's time to switch to something non-steroidal. And it doesn't have to be a fancy brand name, anything. It could be phototherapy. It could be cyclosporin. It could even be for patients who are milder using one of the non-steroidal agents earlier on, tacrolimus, pimecrolimus, crisaborole, right? We have these things that are not necessarily fancy schmancy. I don't have any conflict that would make me want you to prescribe something that's new just because it's non-steroidal. But I think we do have a universe of non-steroidal treatments, including the other hat that I wear, the other part of my life, which is integrative medicine. So doing different types of natural treatments, acupuncture, balneotherapy, spa therapy, whole body cryotherapy, all these other crazy things we can do for the appropriate patient. So I know that's a lot of stuff, but I'll stop there. Thank you so much for having me.
Well, that was amazing. That was it in a nutshell, in a really quick nutshell that was really, really tasty. Wow, amazing. Yeah, you have been at the forefront of this and really championing it for patients. And, I love learning from you. I always love the opportunity to learn from you. And again, I think it's just goes back to show we just really need to keep an open mind when our patients come to us and really listen to them and partner with them, so that they know that we're hearing them and that we're seeing them and that we see the struggle they're going through and we want to help them get better. And you have done that so well. So thank you for doing that, and thank you for educating the future generation of dermatologists. I know this next generation, I do think, is going to do some really special things, especially with this. Like, I think we're going to be part of the starting of it and raising the awareness about it and starting to learn the initial things. But, I call the pre-dupilumab days like the dark ages, right? Like, how many patients did I have on cyclosporin and methotrexate and all this off-label stuff? And again, I think that we're going to look back on this down the road and be like, oh my gosh, we lived in the dark ages. Like, how could we not have recognized this? It was right in front of our face. There's this subset that really, and the whole, potential of genomics and all of that to identify who is this subset that gets this, because so many people just, improve. And I do think it's that you're exactly right, is that elevating pattern, or what do you call it? The advancing
Escalating, exactly, escalating
escalating pattern. Because, and again, that's always when I think as a clinician, I need to start thinking about other things. Like, do I have the diagnosis right? Are they, and I do think noncompliance comes in there, but I think that's where a lot of people stop short, because there is a handful of people that it is noncompliance, but it is a handful. Most of these people want to get better. They're dying to get better. They are struggling and they will do whatever you tell them, And so again, I think, yes, there is a small handful of that, but I think we can't say 90% is noncompliance and it's this other rare subset. It's, the handful of people that are non-compliant. And then we have to think about, is this the wrong diagnosis? And maybe do a biopsy, or maybe, do patch testing. Do you do a lot of patch testing if you're questioning? Because that's where I always go, that because I do think that it can be TSW and contact dermatitis and severe atopic dermatitis. Like, you can have the triad of that.
100% agreed. Absolutely. And I do have patients where I do a lot of patch testing and I love it. And I'll find clinically relevant allergens and maybe they will get better. And maybe that was playing a role, but a lot of times it's still not the whole story. So as you say, there can be multiple things happening. And that's why we kind of have to stick with it to figure out how to get them better.
Right, absolutely. Well, that was so wonderful, but I know you have to jump off. If we get any questions, I may be reaching out to you, and I'll answer them the best I can, but having your expert input would be just such a blessing. And yeah, and you have been so amazing for our community, for ITSAN, and yeah, I get to talk to Kathy Tulos, the president and CEO of ITSAN that I know you've been involved with, and National Eczema Association. And I think you can speak to that too, that getting involved with a patient advocacy organization really just it solidifies everything that you read in textbooks all through medical school. And, just like I've told Kathy in the past, like they've, really done the hard work for us. They have come up with the phenotype of what this is and said, this is what we have, what we have. And nomenclature is so important. And yes, maybe the term is not palatable, but I was on the World Health Organization, the ICD, for the next iteration. And I sat around the table with people from all different countries, and we have to kind of be on the same page to make it so that we can study things together and collaborate and, see a cohesive picture. Because again, if we're just doing it in a vacuum, we're not going to learn as much or as quickly and move the science forward. So again, thank you for taking the time to jump on, and I will see you when I see you next. And again, safe travels and keep doing the good work you're doing.
Thank you so much. Take good care. I'll see you soon.
Okay, sounds good. Bye-bye, Dr. Leo. All right, y'all, T4 friends, that was an amazing cameo performance by Dr. Leo. He really is a great champion for patients, especially those with atopic dermatitis. And as we know, there is so much more that we don't know than what we do know. And over time, we're going to continue to learn more. And I do just want to share my screen real quickly. Because I just want to direct you before we talk to Kathy, who I said it, I shared is the president and CEO of ITSAN, which stands for the International Topical Steroid Withdrawal Syndrome Support Network. So it is an amazing, amazing group. So they have really done some great work over time, and have brought in champions that have started to see this and move the science forward. So thank you to our colleagues who have listened to these patients and learned from their patients. I think our patients are our best resource for information a lot of the times. But I do want to share their website here. And again, it's itsan.org, International Topical Steroid Association Network. I think I might be saying it wrong, but they have a great resource on their website for healthcare providers. It talks about what is topical steroid withdrawal here at the top, topical steroids, coping with it for patients, resources which again are for advocates and for doctors. And you can see here they have shared so much important information about topical steroid withdrawal, what the literature is, and then under their resources here, you can go to the medical and scientific literature, and a lot of this is very high quality literature that is in peer-reviewed journals. And Dr. Leo said, and you know, I do echo the same thing. Our friends across the pond are doing a lot better job of recognizing this, diagnosing it, and moving the science forward on this. And again, it is time to bridge the gap, as we can see here in the British Journal of Dermatology. And again, I do think that in a year from now, we're going to know a lot more. In 5 years, we're going to know a tremendous amount more. And in 10 years, hopefully, no patients will have to be suffering with this. And here, I think it's very powerful. I think stories of patients are very, very powerful. And photos, as we know, are worth, more than 1,000 words. So, these patients, these people, these individuals, have bravely shared their story, and it's such a gift, I think, for other patients going through it to see that there is light at the end of the tunnel. Um, and, you can just see multiple stories here of kiddos and adults that are normal, functioning, happy people before this strikes their life. And it is hard to live through this. And, it's just really important. Again, I know I say this all the time, to listen and to see our patients um, and to hear them, because they are the people living in this skin, and they don't want to be living in this skin. They want and they need our help. And the reason that they've turned from us is because we haven't given them what they need, and that's sad. And you can see, again, the list just keeps going and going and going of these stories, y'all, and we can make a difference. So again, this was a little bit of a tidbit with Dr. Leo, and now we're going to jump on to the T4 P2 patient perspectives with not doctor, she should be a doctor after all the research she's done. She's a nurse, so a healthcare provider herself, who is in pediatric care. Her son has lived through topical steroid withdrawal, and she has just been a champion of this cause and really helped bring a patient voice to it. So I'm so excited for her to be joining me and sharing a bit of what she has seen and learned over time with this condition. So again, thank you so much to all of our subscribers who are tuning in. We thank you. And again, such a privilege and an honor to be able to be a lifelong learner and continue to learn new things and keep an open mind, because that's how we learn. And then to really champion our patients' care and be an advocate with them and just walk along the journey with them. So again, thank you again to Dr. Leo, and thank you as well to Kathy Tulos of ITSAN for joining me here in just a few minutes. And I'm just going to check the chat before I jump into the other screen with Kathy. Let's see. All right, nothing in our chat, but if you do have questions, you can always reach out through the Sages email. And then we are going to be posting these both on the Sages website and on the Sages YouTube channel separately, so that you can dive into either Dr. Leo's talk or the talk that I'm going to be sharing with Kathy live as well. So let me jump on over, and I hope this was informative for all of you. And I look forward to learning with you together. All right, see you on the other side.